Daros la bienvenida a una nueva sesión general del Hospital Universitario Marqués de Valdecilla. Hoy tenemos un ponente especial, un ponente con un currículum académico absolutamente brillante, que viene de la Universidad de Vanderbilt, y quiero agradecer en primer lugar al doctor Nacho del Moral la iniciativa que ha tenido trayéndonos a este ponente de prestigio que engrandece enormemente las sesiones generales de nuestro hospital. Y voy a dar paso al doctor del Moral para que os dé una pequeña explicación sobre el ponente y el tema a tratar. Cuando quieras, Nacho. Gracias.
Muy bien, buenos días. Y voy a presentaros a Matt Weinger, que aparte de anestesiólogo es amigo y yo creo que es una persona que quiere mucho a nuestro hospital. Tuvimos la fortuna de estar trabajando con él durante un año entero, que hizo un sabático y estuvo en el Hospital Virtual Valdecilla trabajando con nosotros en varios proyectos de investigación sobre seguridad de paciente, implementación de tecnología, y luego también como consultor nos ayudó en aquellos años en el pensamiento estratégico del área de innovación del Hospital Virtual que lidera Juan Pedraja. Entonces os decía que Matt es anestesiólogo, además es innovador, tiene varias patentes comercializadas y es investigador, ¿no? Es un investigador nato, es una persona curiosa por definición. Él es catedrático de anestesiología, es bioingeniero también, tiene el grado de bioingeniería en la Universidad de Vanderbilt y en el Hospital Universitario de allí. Y desde que le conozco y él en su trayectoria siempre se ha preguntado por esa intersección entre el trabajo del profesional sanitario, la seguridad del paciente y la implementación de tecnología, ¿no? Cómo la tecnología puede ayudar a hacer nuestro trabajo mejor y a cuidar mejor al paciente, ¿no? Y en este contexto tiene una vasta experiencia y publicaciones, ¿no? Sus dos últimas publicaciones, la primera editorial de la Anesthesiology, que es la revista de referencia en el mundo de anestesiología, la primera editorial sobre inteligencia artificial, la ha escrito él hace unos meses, y luego también ha escrito como coautor el Informe Nacional de Estados Unidos sobre la situación de los profesionales sanitarios en Estados Unidos del Instituto Americano de Medicina. Y hoy nos va a hablar sobre eso, sobre la intersección, la relación entre nuestro trabajo clínico y cómo una tecnología que está incorporándose de una manera disruptiva puede ayudarnos o bien podría ser una pesadilla para los profesionales. Y para eso nos va a dar unos marcos de trabajo y unas ideas. Matt, gracias porque estás de vacaciones y vienes aquí a trabajar hoy con nosotros y nada, adelante.
Gracias, Nacho y Héctor y Ferry. Estoy feliz de estar aquí. Creo que esta es la tercera vez que he presentado a ustedes en los últimos 3 años. La primera vez que no hablaba nada de español, nada. Ahora puedo hablar un poco mejor. Sin embargo, todavía no es suficiente hacer una presentación completa. Por lo tanto, desde ahora hablaré en inglés. Lo siento. Okay. No funciona. Okay, let's see if this works. So, I hope today, by the end, first, if I speak too quickly, you raise your hand, and I'll try and slow down. By the end of this presentation, I'm going to cover three things: the current state and a conceptual model of clinician well-being, the likely uses of AI in healthcare, including how AI could improve clinician well-being, and potential challenges of using AI in healthcare and what you can do now to prevent problems later. So this is healthcare now. We all work to try and keep the rock moving, keep it up. But there are many challenges around the world. So worldwide, healthcare is not cost effective. It's too expensive. In many places, it's not safe. In many places, it's of low quality. It's the wrong care or the right care at the wrong time. It's hard to get care. There's wait lists, or the care that's delivered is not patient-centered. And many of the systems are not friendly to us, the clinicians. We have to work twice as hard to do the right thing. Now, different countries have different problems. In my country, in the United States, it's way too expensive. But if you need an elective procedure today, you get it in a few days. In Spain, it's not so expensive. The care is very high quality, but there are wait lists. So there are trade-offs, but every country has some of these problems. And as a result, the clinicians are demoralized, they're disengaged, they're burned out, their mental and physical health isn't good, and there's a high turnover, people leaving one hospital to go to another, or worse, leaving the profession completely. Now again, the incidence of these things differ from country to country, but it's a problem worldwide. So, the buttons are backwards, Nacho. Okay, so as a result, it's gotten even worse than before. We have sicker patients. The care that we're delivering is greater, more complex, and there's more technology we need to figure out how to use, and it gives us problems. There's shortages. In the United States, there's a big shortage of anesthesiologists. So if any of you want to come to Vanderbilt, you let me know. And so we're struggling. We're struggling under the big rocks. One of the things that you can measure is burnout. And burnout is a framework, a syndrome that consists of emotional exhaustion, cynicism about your work, and a diminished sense that you're actually doing something important. That's why all of us went into healthcare, to make a difference, to do something important. And if day to day we try and get a patient what they need and there are obstacles, we can't do it, then that's called moral injury, and it creates burnout. So burnout is defined as when the demands of the job and the stresses of being a nurse or a physician consistently exceed the resources of the organization and your own personal resilience to be able to do the work. So I did a literature review over the last 10 years of burnout in Spain. And some of the papers are here. If you want, I can share my slides or I can send you the papers. Up to 50% of physicians and anywhere from 30 to 40% of nurses report symptoms of burnout. And I guess I could ask you to raise your hand if you're burned out, but I won't do that. Burnout is associated with anxiety, depression, insomnia, and many other problems. And it was really bad during COVID. You all experienced that, we experienced that, and I thought it would get much better after, but it's only gotten a little bit better, but it's still early because it takes several years after you start a study before we see the results. Now, I want to take you through a model of clinician burnout, of clinician well-being. Nacho's doing a very good job of coaching me in the front here. And to understand how it happens, okay? So let's see if this works. No. Here we go. So that's you. And you feel good, and when you feel good, you and the patient and the organization and Cantabria all have better outcomes, right? Come on. Technical difficulties. Now, there are many factors that influence how you do. So there are all these things, the technology and the other people that you work with, the organization, the Cantabrian and Spanish government, your leaders, and then in the day-to-day work, there are things about you and about the work. And depending on those factors, it changes the outcomes, and that feeds back into the system. So when there are problems, it's a negative feedback, and when there's not problems, it's positive feedback. And those personal and professional resources and resilience hold you up, help you stay strong and not burned out. But when those factors get too much, then your support doesn't help you maintain your well-being, and you get burned out, and the system does not do well. So chronic imbalance of daily work reality conflicts with your needs and expectations. So what does that mean for us? What can we do? So this is where we're at now. And the question is, can AI be a solution? And for many leaders and policymakers, they believe that AI is a superhero. It's the Superman of technology that will solve all of healthcare's problems: clinician burnout, workforce shortages, quality and safety problems, cost problems, access problems. It's like AI is the Superman that's going to make healthcare optimal. Now, we don't know a lot about how AI actually is going to impact healthcare because the publications have only been maybe 8 years, but it looks like this. I did a literature search a few days ago, and there were almost 8,000 papers that had been published, and you can see that the curve is exponential. And the changes are incredibly rapid. I'm going to tell you about some things that are already in the clinics that weren't 2 years ago. And so you're going to see this soon, sooner than you think. So what is AI going to do for healthcare? It's supposed to improve throughput, make us more efficient, decrease costs, improve care quality and safety, change the nature of who's doing what in the workforce, because if I have AI, maybe I can be a surgeon. So the question is, or I'll make it a statement, when we implement AI, is it going to improve clinicians' engagement and well-being, or is it going to make it worse? That's the secret to doing it right. Now, the people who run the hospitals already believe it's magic. So these are quotes from something that just came out last week from CEOs of hospitals. AI has already significantly transformed hospital operations and workflows and continues to advance at a rapid pace. That's true. A different CEO said, AI won't replace physicians, but physicians with AI will replace those without, which means we all, not just physicians, but nurses and biomedical technologists must learn AI in order to be successful going forward. So as a result, we need to be able to learn about AI. I didn't know very much about it 10 years ago, and most clinicians know very little, and they're just starting to play with it on their phones. But you don't want to be the one who keeps your head in the sand while all of these changes happen. So let me tell you about some of the things that are happening right now, okay? So how will AI change what you do? It's going to automate documentation and in many other types of administrative activities. It's going to be used to improve communication with patients, where the AI is between you and the patient, and it's going to improve communication between clinicians. It's going to improve decision-making by making recommendations to you about what might be going on in the moment. And it's going to be embedded in technology and enhance the processes of what we do. So let me give you the best example of AI that is already in use in my hospital and many others. It's called an ambient scribe. And what it is the system is listening, like Siri or Alexa, in the clinic room. It's listening to you interact with the patient, and then it translates those words into text, and then generative AI, like ChatGPT, creates a note, okay? So this automates the documentation, so you don't have to be doing as much of this. It's a good thing, right? And the early U.S. experience looks really good. There's already very rapid adoption. So I saw my primary care doctor maybe 2 months ago, and she pulled out a phone and said, "Can I turn this on?" And I asked her what it was. She said, "Oh, it's DAX Copilot, and I won't use it. I won't do a visit without using it." And that was just within months. She said, "This is indispensable." So how do we know it's good? There's only in the last 6 months have there been publications about ambient scribes. At Kaiser Permanente, the largest hospital, group of hospitals in America that is nonprofit, they used it with 1,000 physicians. At Mass General Brigham, they have a study with 140 physicians. On the next slide, I'll show you the results. At Stanford, they did a small, better controlled study with 48 physicians, and at the University of Pennsylvania, they did a study with 46 physicians. So very small evaluations. But in total, they showed that it was very easy to learn to use it, that when you used it during a patient visit, you spent more time interacting with the patient and less time typing or later writing your notes. That in the United States, we have something that is named pajama time. And what that is the doctor does a full day, or nurse, and goes home and then has 2 hours more work documenting the day. That was substantially reduced with the ambient scribe. One study measured one aspect of burnout, and it was improved. But the people who didn't spend the time to understand how to use it well didn't benefit from it as well. And there's another study that did it in simulation, like at HBB, and they found that there were errors in the documentation. And the doctors and nurses say, well, yeah, it generates a note. It tends to be longer than my note, and I have to go in and get rid of things that aren't important, because the AI isn't yet good enough to know whether the patient is saying something that's really relevant to the visit. Okay? So that's ambient scribes. This is another application called a chatbot. everyone know what a chatbot is, where you talk with the AI and it talks back. So we at Vanderbilt implemented a project where where the AI is taken over. It's implemented a project to try and make messaging from patients to doctors. I don't know if you guys do that yet, but in the United States, the patient can send a text message to a system that the doctor has to review. And as a primary care doctor, I might have 100 messages. And a lot of them I can't deal with because the patient didn't give me enough information. And so the chatbot asks the patient questions and generates a better message so that I can respond once instead of going back and forth, yeah? So this is an example where a patient sends a message and then Claire asks additional questions that the patient answers, and then that note goes to the doctor or nurse so they have more information. Another example is improving diagnostics. There are more than 200 FDA-approved uses of AI in radiology, and they're used to screen films and also to make diagnosis. So on a chest x-ray, the AI will look at it and say, I think there's a cancer right there. So it definitely reduces radiologists' workload. But right now, today, the AI is not good enough for the radiologist to want to use it, and they say that they don't trust it, that it makes mistakes, that it's sometimes biased. Some patients, it can read the x-ray well, and in other kinds of patients it doesn't. Dermatology is an example of AI that is being used to look at skin lesions and make diagnoses, so patients can use it at home. Oh, I have this brown spot, what is it? I'm gonna take a picture of it and the AI will tell you, oh, that's no problem, it's just a sunspot, but maybe it's cancer, right? So they use these to classify, as do primary care doctors, because at least in the United States, we can't, that's one area where we have access problems. We can't get in to see the dermatologist for 6 months. So the primary care doctors want to use it too. There are 41 AI-based apps, but none of them been approved by the FDA, so we don't know how safe they are, and we don't know how patients use them. The next application is predicting the onset of bad things. And this is something Vanderbilt is doing a lot of. So we have about 60 different AI programs running in the background looking at patient information because it's all digital. And one of them, for example, looks at patients who are about to deliver a baby and tries to predict whether they're going to have postpartum hemorrhage so that we can have the right information there. Another one predicts suicide from clinic notes with psychiatrists and primary care doctors. Another one is used to predict whether a patient is going to have low blood sugar while they're on insulin, and we have many others. And now we're starting to get into treatment decisions. So this is a study that's ongoing where they're trying to optimize how much oxygen mechanically ventilated patients receive, because some patients would benefit from lower oxygen levels because of the toxicity and others would not. And so they took the data from a large clinical trial and applied AI to it to see which patients would benefit from lower oxygen and which wouldn't. And then they validated that model that was built with a different data set, and now we've started doing a prospective evaluation. All right, the last part of my talk is going to talk about what the problems could be with AI. For this, I want to take a human factors engineering lens. Now, human factors engineering, if you don't know, is the study of how to optimize, how to design and implement technology and processes so that humans can meet their needs. So it's a human-centered approach to designing and changing AI, for example, so that it meets the patient's needs, the clinician's needs more effectively, yeah? So as Nacho mentioned in the very kind introduction, we just published an editorial about this, so there's the reference if you want to read more about it. And this is the approach that we use, that you have to start with understanding the users and the environment of use, and then you have to be deliberate about figuring out what do users need. Then you iteratively design what you're building, and then you evaluate it, redesign it. You do a final evaluation of what you think you want to put into the clinic. Then after you deploy it, you evaluate it again. So that's human-centered design. Now, with regard to artificial intelligence, what are some of the barriers that we need to overcome? There's still errors and inconsistencies in the information the AI gives us. That will get better over time, but we have to be able to identify when an error occurs, which means you as the doctor using AI needs to know enough about what you're doing to say, oh, that's wrong, I'm not going to do what the AI says. The models can have bias, so if the model is built with only Spanish patients and then you try and apply it in Germany, it might not apply, right? And so you need to make sure that the model represents your patient population, and if that population changes over time, or the care that you usually give changes over time, then the model will drift. By that it means that you're feeding it new information, and it may or may not learn to give you the right answers, or answers that are as correct as they were beforehand. Okay, that's called drift. Humans can be biased. As I mentioned before, some people love technology, some people hate it, and with AI, with automation, there's some people that will, like the radiologist, and I don't want to use that, and try and avoid it even when it's better. Most studies of AI diagnosis prediction now show that it's better than the expert doing it without AI. For example, diagnosis of appendicitis in the emergency room. But AI plus the expert is best most of the time, okay? And then there are those who love the AI and believe it, or they're lazy, and they'll accept it even when it's wrong. And so that's why it's so important to train the next generation of physicians and nurses to be able to use AI, but to be skeptical, I can't speak English either, and to know enough about the patient and the situation to say, that doesn't seem right, I'm not going to do that. Designing the AI so that it doesn't slow you down or comes at the wrong time so you can't use it optimally is a user interface or design challenge. And then there are implementation challenges. And in the last few minutes, I'm going to talk about the last two issues, the implementation, okay? So if the AI is not designed properly, or if it's implemented in a way that doesn't allow you to use it when you need it, so say it's not at the right time in the workflow, so you're already moved on working on something else in the visit, and now the AI is telling you to do something that you've already done before, that's not a good design, right? So it has to be aligned with the workflow. And my colleague, Dr. Salway, who I published the editorial with, that's her big area of interest, is how do you figure out when does someone need information, what information do they need, how do they need it, in the moment that they're taking care of patients to optimize efficiency. AI can be used to promote care that are not in either the clinician's or the patient's interest. So if it's designed in a way that it's based on population data, but this patient in front of you doesn't fit those clinical trials or has preferences that they don't want chemotherapy because it will cause neuralgias and they play the guitar, whatever it is, the AI says, oh, you must start chemotherapy, and the clinician, the patient, no, we don't want to do that. But if you don't implement it correctly, there'll be organizational pressure because they'll call you, why didn't you do what the AI said, right? So we need to be careful that doesn't happen. And I think most importantly for burnout, if AI is implemented incorrectly so that it's telling you things you don't want to do, it's telling you things that aren't appropriate in the moment, it replaces your feeling of autonomy that I'm taking care of this patient, and it degrades your expertise by, I don't have to think about that anymore, the AI is doing it, then it's going to increase burnout instead of decreasing it, okay? So we don't want to replace clinician and autonomy and expertise because then you're not going to be as good as you were before. So the question is, how can we best develop and use AI to improve both clinician and patient well-being, as well as achieve all those other benefits that AI could potentially achieve? So I would argue that the best path forward is to first, using human-centered design the AI to focus on the needs and values of the people doing the work and their patients. And right now, a lot of AI is being designed in an office by engineers and presented to the CEOs of the hospital. Look, isn't this great? Yes, let's use it. And that's when you're going to have problems. And moreover, even if a good, well-designed AI is given to the hospital, if it's not implemented in a way that optimizes the needs and values of you, the clinicians, and the patients, then it's not going to be effective. It may meet some of the goals of the C-suite, of the leaders of the Ministry of Health, because maybe wait lists would be shortened. But if the clinicians are more miserable because of that, in the long run, it's going to be worse. So by using human-centered design applied to the entire user experience, defining the user as the clinicians and patients who actually do the work, then you're most likely to end up with a situation that is beneficial to everyone, including the hospital and the healthcare system. So what are some design goals? If tomorrow someone comes and sits down with Ferry and says, here's a new AI that's going to improve transfers from the operating room to the recovery room, what should you be thinking about? First, you should say the clinicians and the other users of the AI need to trust the AI. And so the reasons it gives answers has to be transparent, or at least consistent with what you would have done yourself, right? The communication between the AI and the clinicians, the users, need to be clear and consistent. And we're discovering this is particularly true when the AI is uncertain. And so we're starting to design user interfaces where the AI is saying, I think you should do this here, but my data only tells me 60% and not usual 90%. So that way, when I look at it, I say, well, I don't know about that. I think maybe this is, or you can interact with the AI and say, well, you didn't know this about the patient. Now what is just like you do with ChatGPT. By the way, a little audience participation. Who uses ChatGPT or something like it on their phone? About a little more than half, about half. In the United States, it's 100%. Okay? So we're using it at home, right? With all the same problems. Sometimes it gives you garbage, sometimes not. But it's helpful overall. But we're wise consumers, right? All right. It needs to support autonomy and mastery of the clinician and of the patient. Many patients want to feel like they're in control of their disease. And I think this is more true in the United States than in Spain. But a lot of times they want to do it themselves. They don't want something telling them how they should live their life. Can you imagine an AI, you go to dinner and your phone is an AI from the hospital says, oh, don't eat those rabas. No come los rabas, es mal, see? So we don't want to implement it that way. And then really important, last big point is that the hospital and the healthcare system have to have an infrastructure and a governance to make sure that the AI that they implement achieves all of those goals, okay? And it needs to explicitly monitor and address all of the potential issues, including ethical issues, which I did not have time to talk about. So my take-home message, using human-centered design of AI tools and associated processes need to focus on the primary goals and values of the end users, okay? What are the needs of the patients and the dermatologist or the cardiologist in that moment, and how is AI helping? We need, as we implement, we need to have an organized structure with extensive feedback from the people who are actually using it to say, oh, this works, this doesn't work. We need to identify what kind of training everyone receives, and as people use it, we need to give them feedback, useful feedback that says, oh, well, you aren't using it as much, but I've looked at your patients and actually you're doing okay. Or rather than just saying everybody else is using it 90% of the time and you're only using it 60% of the time. The institution has to have a committee, a governance and oversight committee, and then after you've implemented, there's a new word called algorithmovigilance. I'm looking forward to seeing what that'll be in Spanish. And it monitors the performance of the AI over time to identify that drift that I talked about. So changes in how things are being done or changes in the data that's going in so that you know that the AI is still as good as it was before. So in conclusion, we want our envisioned future to have AI be a partner who's helping to hold up the big rock that is healthcare in order to improve overall health of our population, that's more effective, is safer, there's less disparities between different kinds of people, it's more efficient, it's lower cost, and I should have put smiles on the clinician's face, they are más feliz. Vale, gracias.
Thank you very much, Matt, for your excellent presentation. Are there any questions from the audience? ¿Alguna pregunta que tengáis que hacer para Matt? No sé si en español o en inglés. Mejor en inglés.
Te voy a hacer una pregunta en español.
Ok.
Entonces, hablas de que en Vanderbilt se está implementando la inteligencia artificial ahora.
Sí.
¿Qué recomendaciones darías para un lugar que quiere comenzar a utilizar la inteligencia artificial, como este hospital?
Explicaré que Vanderbilt hacen, ¿sí? Does, and then translate. Okay, so at Vanderbilt, we have a committee that focuses on all of the AI in the hospital, and they get reports every week on what each AI program is doing. This is the algorithmovigilance. And they review the data to make sure each AI application is continuing to do what it's supposed to do. When Nacho comes and says, I have a new AI that will improve something, will make blood transfusion criteria better so that we don't give too much blood or too little blood, then they review all of the information about how that AI works and why it's going to be useful, and then they help to design a pilot evaluation, say in one unit in obstetrics, and evaluate the data, and only then do they then agreed to let it be rolled out in other units, and they continue to monitor it. So that organization, that infrastructure and governance is absolutely essential. So here, you're just at the beginning, and so you have an opportunity to create a committee that can think about these things before you even have to worry about them. The worst thing is for each doctor to, oh, this AI is great for my practice, I'm going to start using it, without any oversight. So as much as my team that builds AI don't like the delays of the review and such, it's important. Gracias.
Any more questions? ¿Alguna pregunta más que tengáis? Doctor Ramón.
It's not. Thank you for your talk, and it was very inspiring. This is not a question, but more or less a comment that the problems we have here now in healthcare are of a nature that doesn't improve just adding more and more human resources to them. I mean, we could hire as many people as we want if we had enough money, but they would still be fewer than we need. And I don't think that, for example, you mentioned several times radiology. We have in this hospital we are doing radiology 7 days in the week, 24 hours a day, even on weekends, and we still have waiting lists. So that won't go away hiring more radiologists. You need some kind of different approach to the problems we have. And I think that AI could be something like that. I'm not a radiologist, of course, but I know that about those problems. And the second thing is that I think that if AI is going to be used as a diagnostic and therapeutic tool, it should be subjected to the same regulation as other medical devices or drugs are going to be used. And I don't know if that is the role of the hospital as you are trying to do, or if it is the role of, oversight, health authorities and so on.
So 2 really good questions. I'll answer the second one first. AI that meets the criteria for a medical device, which is most of the things that I presented for diagnosis and treatment, all of those are going to be regulated as medical devices, and both the FDA and the EU and other global regulatory agencies are busy creating frameworks to evaluate AI. And most of the original AI up until 3 years ago was not generative. Like, it wasn't ChatGPT. It was easier to regulate because it didn't change over time. Now they're trying to figure out, because ChatGPT learns, right? And so that's more difficult to regulate because you're doing it at a snapshot in time. And so what the FDA and EU are doing is creating systems which will require the company with the application to report outcomes on a regular basis. But I agree with you entirely. It has to be has to be proven safe and effective now and as it's used. For your first question, I will politely disagree with you a little, okay? Un poco. I think the bigger problem in Spain is that you have not digitized your care processes, because in the absence of that, the data that we have to figure out what the problem is not very good. So that's the first step, is to develop a digital healthcare system. I'll tell you briefly an example. The cardiologist at Vanderbilt, this was 10 years ago, we studied it. The cardiologist at Vanderbilt said, we need to build more catheterization labs because we can't get enough patients through. And so Dan France and other members of my team said, let's collect data on every patient who needs a cardiac catheterization for whatever reason and track where they are through the system and when they get each type of care. And we created a model that I can show you the flow of the patients. And what we found was the problem was not that we didn't have enough catheterization laboratories or that we didn't have enough cardiologists. The problem was the cardiologists we had weren't willing to work at the times that the catheterization labs were all open, in the evenings, on the weekends. So there weren't enough of the doctors that were available to staff the existing catheterization labs. And they changed the scheduling. The cardiologists were only a little bit unhappy, and they solved their problem with efficiency. Now, I'm not saying that is going to be the solution to the radiology problem, but I'm saying you don't know until you have the data to examine it. Thank you for the question.
¿Alguna pregunta más? Any more questions?
Gracias.
Thank you very much.
Nacho.